Hello, my name is Jay Huang. I'm a fourth year pathology resident in the States. I go over cases almost on the daily from head to toe. If you're interested in that, please give a like and possibly subscribe. Let's go to this Johns Hopkins Medicine Surgical Pathology Unknown Conference. All right, this is week 813, case 2, presented by Dr. Lisa Rupert and prepared by Samuel Law. This is a 50-year-old male with a nasal mass. So here we see a curettage of pretty bloody fragments with maybe bone and fragments containing basophilic cells. So as we look closer, we look as what looks like cells that have kind of a cribriform architecture. However, it's kind of hard to tell because they can be salivary glands that have cautery effect. There is background inflammation and hemorrhage. So we see thin ribbons of basaloid looking cells, and we see nests, large nests of cells with reminiscent of a cribriform architecture. Here we see definitive cribriforming with the basaloid feature. This looks like adenoid cystic carcinoma, right? And some of these cells do look atypical. They're pretty hyperchromatic. I actually did this case just a minute ago. I clicked adenoid cystic carcinoma. However, this was HPV-related multiphenotypic sinonasal carcinoma. So I find these very difficult, and you do need ancillary studies. So histologic sections are composed of pieces of tissue with exuberant chronic inflammation in areas of cribriform glands and squamous pearl formation. Here is the squamous pearl, with scattered areas demonstrating basaloid morphology. This case was positive for HPV in situ hybridization IHC. The IHC findings and the combined presence of cribriform glands and squamous differentiation points to a diagnosis of HPV-related multiphenotypic sinonasal carcinoma. HPV-related multiphenotypic sinonasal carcinoma is a neoplasm described as recently as 2013 that is located exclusively in the sinonasal tract and is noted for its strong association with HPV 33 and its negativity for MIP and FIP, which is 6-9 translocation in adenoid cystic carcinoma. Very board-worthy fodder. This tumor was formerly known as HPV-related sinonasal carcinoma with adenoid cystic carcinoma-like features. It is noted for its wide age range and high-risk HPVs detected in all reported cases, with HPV 33 detected in 68%. The usual histologic features include areas that resemble adenoid cystic carcinoma with tubular, cribriform, and solid patterns, as evidenced by biphasic ductal and myoepithelial differentiation, as well as squamous and basaloid differentiation. Rarely, sarcomatoid areas with staghorn vasculature or heterologous mesenchymal elements may be present. Based on the curated case in the literature, this neoplasm is associated with high frequency of late local recurrence, decades after initial surgery, but distant metastases are rare. Current treatment revolves around surgical resection with negative margins and sometimes radiation therapy. Though adenoid cystic carcinoma shares morphologic overlap, adenoid cystic carcinoma would not be positive for high-risk HPV-ish and has no known association with HPV infection. Adenoid cystic carcinoma would also have a MIB and FIB 6-9 translocation in most cases. Sinonasal squamous cell carcinoma would be characterized by predominantly squamous differentiation and no biphasic morphology nor myoepithelial differentiation. Lastly, SMARCB1 deficient sinonasal carcinoma would demonstrate INI1 BAF47, which is SMARCB1, lost by IHC, and it will be HPV-ish negative. Well, that was the video for today on multiphenotypic HPV-related multiphenotypic sinonasal carcinoma. I will see you next time. Bye.